So good evening, everyone. I'm Dr. Vishwanath S, Senior Consultant in Medical Oncology at Apollo Hospitals, Bangalore, and the Managing Trustee of CPOM Foundation, and I'll be the host for tonight. And we welcome you again for our ASCO-endorsed CPOM webinar series. And the topic for tonight is managing head and neck cancer and focus on neoadjuvant and metastatic setting. And uh, our sponsors for tonight. One second. Our sponsors for tonight include OncoMinds and NATCO, and we are grateful to them. And a few ground rules before we start. Please ensure that your internet connectivity is good to have a seamless experience. And by default, all the attendees will be in mute and listen-only mode. Attendees can also choose to ask questions by typing in the Q&A section, and this session will be recorded. A few words about our organization, which is called Creative Portal for Oncology Education and More. It is a not-for-profit organization tasked with educating practicing oncologists and trainees, and a portal for increasing access to patient resources and improving awareness globally. So this is our CPOM team. Myself, Dr. Vishwanath is the Managing Trustee, and we have Dr. Poonam Maurya, Dr. Chandrakant, Dr. Santosh, and Dr. Rachan Shetty as other trustees. And this is the agenda for tonight. So we have the first talk on the role of neoadjuvant systemic therapy in head and neck cancer, a focus on the recent trends, which will be given by Dr. Rajiv Rajendranath. And the next talk will be on managing metastatic head and neck cancer in the era of immunotherapy. This will be by our speaker, Dr. Anna Spriafico. And this will be followed by an interesting talk by our surgical oncologist, Dr. Ratan Shetty, which will be on salvage surgeries in persistent and recurrent head and neck cancers. And this will be followed by two interesting case presentations by Dr. Padmini and Dr. Ram Gopal Rao Walla. And this will be discussed by our experts. And then we'll have a few concluding remarks by Dr. Poonam Maurya. Now I call upon Dr. Santosh Kumar Devdas, professor at MS Ramaiah Medical College in the Department of Medical Oncology, to introduce our guest speaker, Dr. Rajiv Rajendranath, and also introduce his topic.
Can you share the slides, Dr. Vishnu? I can also share the slides if possible.
No, I think this is the slide.
I got the slides, okay, right. So, thank you, Dr. Vishnath. It's my pleasure to introduce Dr. Rajiv Rajendranath, who is a senior consultant medical oncologist at, I think, Apollo, Chennai. He's done his MBBS and MD internal medicine from KMC Mangalore, DM medical oncology from Adyar Institute, and DNB from medical oncology in 2008. He was a professor and teaching faculty at Cancer Institute Adyar till 2015. His special interests are breast and gynec oncology, head and neck oncology, GI and GU oncology, and geriatric oncology. He was awarded the KS Sanjeevani Award in 2013 for outstanding medical contribution for the poor and needy. He also was awarded Best Doctor Award by TN MGR Medical University in 2011. He's a honorary senior consultant medical oncologist at Southern Railway Headquarter Hospital and a senior medical oncologist at Apollo Cancer Center, Chennai. He's a clinical lead for geriatric oncology at Jerry Care Hospital in Chennai. His topic that he's going to talk about is the role of neoadjuvant systemic therapy in head and neck cancer, recent trends. Over to you, Dr. Rajiv, sir.
Good evening, and thank you so much, Dr. Santosh, for the kind introduction. And I also thank Dr. Vishwanath and the team for giving me this opportunity. So the topic is sort of a prelude where I am going to speak on the neoadjuvant, and then we'll have the international speaker talk on the metastatic setting, which will be more relevant and more interesting as far as immunotherapy is concerned. So let me start off with my presentation of neoadjuvant systemic therapy. So I think at least few years back, we would have told neoadjuvant chemotherapy in head and neck cancer and recent trends. So it's heartening to see that we are looking at neoadjuvant systemic therapy. So if you look at the Indian perspective, and that's what we are here for, if you look at the 37 population-based cancer registry, you can see that India shows higher age-adjusted incidence rate for mouth, tongue, and hypopharynx cancer compared to other countries for both genders. And we know it is due to the menace of the smokeless tobacco, and more worrying or more practical for our Indian oncologist is that more than 65% of the patients with head and neck cancer attend the hospital with locally advanced disease due to multitude of reasons like lower socioeconomic status, neglect, and the coexisting leukoplakia and inflammation in the oral cavity, and so on and so forth. So this is the perspective that we are looking at. And when we look at the milestones in systemic therapy for locally advanced head and neck cancer, it all started with single agent methotrexate. Then we had the platinum coming in big way. Larynx preservation was a landmark trial where we looked at induction chemotherapy for the first time, and thereby we could preserve the organ. Then from 1919 to date, it is the concurrent chemo RT with platinum plus or minus taxanes, which I'll touch upon in some of the later slides. And some lot of interest in the early 2000s for de-escalation trials in HPV positive oropharyngeal cancer and the controversies along with it. And I would look at the new kids on the block, new adjuvant targeted therapy and immunotherapy also. So if you look at the neoadjuvant approach in general, especially if you look at other solid organs like lung cancer and breast cancer, the intent is very clear. We try to make the job easy for the surgeons, one. We try to reduce the incidence of metastasis, one. And more importantly, if it is a critical organ, we look at the organ preservation. So these are few of the basic prerequisite or the target for the neoadjuvant therapy, and the head and neck cancer also is no different. It has some very appealing theoretical advantage. There is optimal drug delivery to the tumor because it is an not operated site, and we have the undisrupted vasculature for our drugs to go and work better. We know that most of the cancers, including head and neck cancer to an extent, is a systemic disease, and we'll have early eradication of micrometastasis if you use the neoadjuvant approach. We know that the concurrent chemoradiotherapy that we use and the dose of cisplatin that we are using there is more of a radiosensitizing dose rather than a cytotoxic dose of micrometastasis. We also see generally if there is an organ or tissue in situ, then there is improved tolerance of cytotoxic drugs rather than after a supra-major surgery. Majority of our patients nutritionally go down, and the adjuvant chemotherapy is a real challenge to give. And more importantly, it is a in vivo lab for us to find out that the tumor shrinkage will help us understand the biology of the disease. And more importantly, as I told, when we have these locally advanced, ugly looking tumors, which are obviously unresectable, they may come into the purview of surgery and thereby to a purview of potential cure. So these are all theoretical advantage. More importantly, as I told, it will also give us the opportunity of assessing tumor response and whether we can tailor accordingly in the adjuvant setting. So just a bit of history, we know the TPF protocols, the TAX 323 and TAX 324 from the URTC group, which looked at the comparison of the 3-drug regimen, the docetaxel cisplatin 5-FU versus cisplatin 5-FU, and then RT alone. There was TAX 324, which was the slight improvement where we felt that RT alone after induction chemotherapy may not be good enough. So the TPF PF arms were compared to carboplatin plus RT. There was a lot of interest and excitement when we were residents, thinking that this would be the new way to go. And there was definitely a trend in improving the response rates, and there was some improvement in the progression-free survival rate. But coming to the Indian setting, there was interesting data coming from Kidwai Institute of Bangalore during that time, that tolerance for the 3-drug regimen is a problem in Indian setting, especially with the nutritional issues. So we need to select our patients better. And also, another interesting aspect was when the patients were much better after the induction chemotherapy, and we had a complete clinical response, which is the best scenario from a medical oncologist point of view. There was a lot of dropouts from the surgery and chemo RT arm. So these were a few things which we learned when we used the TPF regimen as per the TAX 323 and T34. But then we found after a lot of meta-analysis that the induction chemotherapy in head and neck cancer may not improve survival, will reduce the chance of distant metastasis, and the updated meta-analysis of the head and neck, the MAC-NC, suggested that induction chemotherapy and concurrent chemo radiotherapy might have complementary effects on disease control. But still, most of us practice concurrent chemoradiotherapy as the standard of care in majority of the sites, and that is because we could not demonstrate a significant overall survival advantage in across subsets with the neoadjuvant approach. A lot of studies which looked at different subsites. So when we had this Van Moken et al. Study which looked at the unresectable oropharynx, and all of the places we could find that there was improvement in median PFS and OS, and there was increased response rate, which again we needed, but the CR rates were 8.5% versus 6%. So we had Posner et al. Data, Hit et al., Pointry et al., all looking at different subsets and giving a different combination of TPF, then give chemoradiotherapy. Most of the time, it would be carboplatin plus radiotherapy. There was one trial looking at cetuximab plus radiotherapy also. So there was this trend of induction TPF followed by concomitant treatment versus concomitant treatment alone. And this also was a randomized trial. And there can be seen a statistically significant improvement in the induction chemotherapy arm. So when do you use induction chemotherapy in locally advanced head and neck cancer? Mainly for larynx preservation, which is almost the standard of care. If you can't do a partial laryngectomy or laryngeal preservation surgery, it would be usually an induction chemotherapy approach, because that's the best way to preserve the larynx. For treatment intensification, well, we need to debate that. For borderline resectable, we have trials from Tata Memorial Hospital and other Indian centers that most of the borderline resectable or unresectable oral cavity cancer, there is a case for argument for neoadjuvant chemotherapy. There is a to look option of doing a tailored therapy, whether de-escalate in HPV positive. Well, that's not very accepted. So if you look at the laryngeal preservation study, this again was RTOG studies many years back. They looked at cisplatin 5-FU induction followed by radiotherapy. These induction chemotherapy with TPF studies also looked at the laryngeal preservation, and we can see that induction chemotherapy with TPF can be considered as a standard approach for patients with advanced laryngeal cancer or hypopharyngeal cancer who are not eligible for a organ preservation surgery. Of course, the other approach again, we would select out patients, would be use a concurrent chemoradiotherapy, where also we can get a organ preservation approach. Now, this second option, which I told about the induction chemotherapy for treatment intensification, again, there was individual randomized trial, which include the paradigm trial, where they looked at 3 cycles of TPF, then follow it up with the concurrent chemo RT. Unfortunately, the intensification protocols could not provide a survival advantage or an overall survival benefit for it to become the standard of care. So as I mentioned earlier, concurrent chemoradiotherapy remains the standard of care, at least for majority of our patients. This was the area of interest, especially as I told for the Indian patients, where most of the patients are locally advanced, borderline resectable or unresectable. Again, we had these subsets, and they looked at patients who had this approach of induction chemotherapy and found very good responses. More importantly, the papers from India showed that this may increase the chance of resectability, especially in very advanced unresectable, and subsequently might improve outcome. Though we did not have head-on-head comparison between concurrent chemo RT versus neoadjuvant chemo followed by surgery. As I told, selection tool for RT dose de-escalation, lot of noise and lot of excitement a decade back, but there is as of now no clear evidence for us to do that. And now we come at the recent trends, induction chemotherapy with targeted therapy and immune checkpoint inhibitors. So it will be the first trial was induction chemotherapy followed by either chemoradiotherapy or bioradiotherapy for larynx preservation. This is the trampoline. It was a phase 2 randomized study. So 3 cycles of TPF, then the randomization happens for cisplatin RT versus cetuximab RT. And at least that trial could tell that cetuximab may be non-inferior and can be a good option if you cannot give cisplatin after induction chemotherapy, because giving cisplatin after 3 cycles of TPF is going to be quite challenging. So these are the few of the phase 2 trials looked at investigating cetuximab with a platinum compound and taxane. And in most of these trials, these combinations were found to be feasible, and the response rate was between 70% and 97% and were promising. So this is one way to look at giving induction chemo and then follow it up with a targeted therapy. So this is again looking at platinum compound and taxane, and then at some point cetuximab. The responses to neoadjuvant targeted therapy in operable head and neck cancer confers survival benefit. So this was an interesting study which showed that whoever who had a downstaging with a neoadjuvant regimens with EGFR inhibitors or anti-HER2 antibody therapy will have a survival advantage. But these are small trials and have not picked up to become standard of care. Cetuximab versus control in the 2 week before curative surgery, which was an interesting concept. Again, it showed that it is safe to use, and there was some good responses, and also some interesting metabolic response in PET, which will tell us, like in lymphoma, that who are the patients who are going to benefit by having a good response to this 1 or 2 doses of cetuximab. This was a URTC study. Again, interesting in Indian context because afatinib, we have the generic brand and we have oral drug, and they could show that 70% of the patients had a metabolic response, and it was a sort of proof that this is another way of looking at treating patients who otherwise may not be fit for an induction chemotherapy. So there was a lot of interest. We had erlotinib, lapatinib, cetuximab, dacomitinib, all with reasonably good tolerance profile, and the trial duration ranged from 2 to 6 weeks, and there was no delay in surgery. And that was a proof of concept sort of approach, but it's again not standard of care as of now. So the interest now, we will know that from the next talk, that the immunotherapy, the PD-1, PD-L1 inhibitors has come up in a big way in metastatic head and neck cancer. So why not we use neoadjuvant or a neoadjuvant followed by adjuvant immunotherapy? Again, a lot of rationale to use immunotherapy in the neoadjuvant setting. The settings like lung cancer is a good teacher for us, which shows that it can engage the immune system when while much better while the bulk of tumor antigen are in place. There can be transfer of cytotoxic T cells in a better way in a neoadjuvant setting, and it may have much more T cell reactivation and responses and a strong adaptive immune response. So again, the theory for neoadjuvant immunotherapy is quite strong. And as in any other setting, neoadjuvant immunotherapy has its advantage of early control of micrometastasis and so on and so forth. But then the caveats is we should be aware of the early disease progression or hyper progression, where it will be really not favorable for a patient who otherwise would have gone in for concurrent chemoradiotherapy. So we need to be careful of this also. So there was very interesting trials which looked at neoadjuvant nivolumab. So in a newly diagnosed, these were resectable cases. You give just day 1 and day 15 nivolumab, and then they take it up for surgery. Then they did the risk stratified standard post-operative treatment. This was for the stage 3, 4, again, resectable head and neck cancer. You give just one dose of pembrolizumab and then the surgery in 2 to 3 weeks. And this trial came out with the concept of pathological tumor response. That means how much is the necrosis and the keratinous debris, and then you calculate the viable cells, and you sort of differentiate them into PTR 1, 2, and 3, and look at the improvement in survival based on the response to immunotherapy. So it was always again a proof of concept study, which says that even one dose of immunotherapy had some response to before you give it for surgery. So these are the entire trials, recent trials, which we are looking at with the single agent PD-1 inhibitor in head and neck cancer. Reasonable pathological response, but good clinical response also. But this alone might not be the way to go forward. So if you look at the immunotherapy studies, a lot of studies happening in between 2021 and 23. Many of them are going to be matured in the next 1 or 2 years, and we'll have maybe some new standard of care coming in. So conclusion from the single agent PD-1 inhibitors says that it is safe, that is a low risk of hyperprogression, which we were worried in other subsets. Longer duration of therapy may increase the pathological response, because with 1 or 2 doses, the responses are very modest. And pathological response to pembrolizumab had some correlation with PDL1 expression. So then the look at adding dual IO, that is ipilimumab to nivolumab. Again, there was slight improvement in response rate when you have the dual immunotherapy agents. And again, a lot of preoperative trials with immunotherapy combinations happening, and we hope it will mature and soon, and we'll have a positive data. Of course, like in many other settings, including lung cancer, neoadjuvant immunotherapy plus chemotherapy may be the way to go. So this was the nivolumab study, where they give neoadjuvant 6-weekly infusion surgery and then come out with the post-operative standard of care. So here the PCR was the primary endpoint. And this was an interesting study which was published in 2023, where durvalumab plus chemotherapy was considered. Small study, 39 patients, but then you could see that the PCR was almost 30%, and the major pathological response happened in 49%. Again, giving proof of concept that chemo immunotherapy may be the way to go in a neoadjuvant approach. Lot of studies again happening in this setting as well, of combining immunotherapy plus chemotherapy. So as I told earlier, the recent Indian data, again published by Vanitha et al. From Tata Memorial, that from India, that showed that it was a phase 3 randomized controlled trial comparing docetaxel platinum versus TPF as neoadjuvant chemotherapy only in borderline resectable oral cancer, and which showed that there was improvement in the resectability as well as survival in TPF, and the authors concluded that the 3-drug regimen may be the way to go rather than cisplatin 5-FU alone. This again very recent, published in 31st July 2024, where they are looking at chemo-free with the neoadjuvant chemotherapy, pembrolizumab plus cetuximab. Again, very exciting. And if you look at the Tata Memorial data, there was the improvement in overall survival. And more importantly, if you get a pathological response with the pathological CR with the TPF, your survival is very, very high. So that's again we have seen in other subsets as well. So this is the small study from China which looked at pembrolizumab, cetuximab plus neoadjuvant chemotherapy. Again, this may be a novel way to go because they had very impressive results. So I would conclude by saying that it is again an MDT decision whether we should use induction chemotherapy. It is not one set treatment for all. we should be worried about the treatment courses, and especially in this Indian setting, a patient's fitness to undergo a TPF sort of regimen before we embark on that. And if they are not able to tolerate chemotherapy, we should be very careful to put them in induction chemotherapy. I would say the role of immunotherapy is much more exciting. Both neoadjuvant and adjuvant immunotherapy trials are appealing. You may have the combination IO or combination with chemotherapy, which can increase the response rate. And there are a lot of phase 3 trials which I showed, which are ongoing. And I'm sure that a subset of our patients may benefit, but the patient selection with the biomarkers need to be optimized before it becomes standard of care. Thank you. And again, I thank the organizers for the opportunity.
Uh, Thank you, Rajiv sir, for that very insightful talk. And if you can, yeah. So I will introduce Dr. Anna Spriafico, who is one of our guest speakers for tonight. Thank you, Dr. Anna, for accepting our invitation and to be part of this ASCO endorsed CPOM Foundation webinar. So Dr. Anna Spriafico is the clinical investigator at the Princess Margaret Cancer Center, Cancer Clinical Research Unit, Princess Margaret Cancer Center. And she's also affiliated with the University of Toronto and staff medical oncologist and clinical investigator in Division of Medical Oncology and Hematology at the Princess Margaret Cancer Center, University Health Network. She has a PhD in translational research in the program for evaluation of targeted therapies at the University of Colorado, United States, and a subspecialty fellowship in head and neck cancer and experimental therapeutics in the BRAS Phase 1 program at the Princess Margaret Cancer Center. Dr. Spriafico is the head and neck medical oncology disease site lead and clinical investigator within the tumor immunotherapy program. She also serves as the director of the Phase 1 Drug Development Fellowship at the Princess Margaret Cancer Center. Dr. Spriafico's full-time academic practice and her research focus is mainly on early drug development and Phase 1 clinical trials, with disease-specific interests in melanoma, skin, and head and neck cancers. She is also the principal investigator of numerous early phase, first-in-human and first-in-class trials, and investigator-initiated biomarker-driven studies for which he holds large-scale peer review funding, including the Canadian Cancer Society and the Canadian Institute of Health Research. She is a recipient of several national and international awards, and in the last 5 years, she has published over 50 peer-reviewed publications in widely cited journals. And we now call upon Dr. Anna Spriafico to give her talk on managing head and neck cancer, especially in the metastatic setting in the era of immunotherapy. Over to you, Dr. Anna.
Thank you very much for this kind introduction. I'd like to thank the CPOM organizing committee as well as ASCO for the opportunity to invite me to speak about managing metastatic head and neck cancer in the era of immunotherapy. Here's my disclosures. So as an outline, I'll be touching base on head and neck cancer, the various subtypes and the treatment as well as the metastatic presentation. And then we'll discuss very briefly again about advanced disease and the role of palliative chemotherapy and molecularly targeted therapy. However, the bulk of this talk will be focused on immuno-oncology portfolio in head and neck cancer, particularly the current status, so what is the standard of care, and I'll spend quite a lot of time on this. But I also touch base regarding some recent clinical trial and the outcome of such trial, and then mention some of the ongoing research in the oncology, in the immuno-oncology aspect for head and neck cancer. So when we're talking about head and neck cancer, we often, for these who are not necessarily involved on a day-to-day basis, people think that head and neck cancer is one type of cancer. However, I would argue that there are many different types of cancer. It's based on the location, but these type of cancer behave different. They have pathological and molecular different features that led to a different prognosis and response to therapy. And therapy needs to be personalized. For example, in oropharyngeal cancer, we know that HPV makes a huge difference with respect to their response to therapy as well as prognosis. And it is the HPV-related disease has become very, very frequent and prevalent, I would say, in North America. But other type of cancers such as hypopharynx, larynx, and oval cavity, and overall, these type of cancer are unfortunately treated often with very similar methodology, where personalizing therapy needs to really be brought to the attention of these various type of cancer. There's also different type of more rare cancer within the head and neck, including nasopharynx and salivary gland, and we will not be touching upon those today. So as I mentioned, when we look at the staging, for patients who are diagnosed with localized disease or local regional disease, the treatment will be defined as curative upfront, and you can see here the distribution. So many more patients are diagnosed with local regional disease, and the overall survival drops dramatically when we go from localized cancer to local regional cancer. Surgery and or radiation therapy is used often for localized disease, where we know lots of the toxicity will come acute and long term, and it will impact the quality of life of these patients. In the local regional setting, chemoradiation versus surgery followed by radiation or chemoradiation, with accounting for HPV disease is important to consider. Patients who are diagnosed with metastatic disease have a very poor overall survival outcome, and systemic therapy is generally prioritized. When we're looking at metastatic disease at presentation, patients who fortunately at presentation, patients with head and neck cancer are not very common. So 10 to 15% of patients are diagnosed with metastatic disease up front. So the good news is that we cure a lot of the patients. Unfortunately, for those patients who have recurrent disease or are diagnosed with metastatic disease up front, their prognosis is very poor. What is the goal of the therapy? Well, certainly palliate symptoms, improve overall survival, as well as improve quality of life, which is paramount when patients are diagnosed with advanced disease. Common sites of metastasis can be lung, bone, or liver, and other, nevertheless. The more the patients live longer, the more the site of metastatic disease can come. And you might have seen several patients developing brain metastasis as well, which was not thought to be very common in the past. Now, we have used over the past years, we heard from the previous talk, excellent talk, chemotherapy, which I would define it as a non-specific approach, using taxane, platinum-based chemotherapy, as well as other antimetabolite. And chemotherapy, many years ago, had not shown any major benefit in increasing overall survival, as we know that median overall survival without chemotherapy, without treatment, I would say, it's 4 to 6 months, and there's not much of a change in median overall survival when chemotherapy was added, looking at various combination treatment or either methotrexate. Here's a study, very old study, looking at comparing platinum doublets such as cisplatin 5FU, paclitaxel cisplatin, with no changes in the survival probability. So what do we actually know about palliative chemotherapy? Well, we know that without treatment, the median of survival is poor within 6 months. It doesn't improve much when we add chemotherapy. The doublets palliative chemotherapy has an overall response rate of about 25 to 30%, but does not change the overall survival, as I mentioned. And these treatments are toxic. They can cause myelotoxicity, nausea, vomiting, diarrhea, and we know how our patients feel when they're receiving chemotherapy. So within the various old markers of cancer that are kind of summarized in this cartoon, for head and neck cancer specifically, there's been particular interest in targeting EGFR inhibitors. We heard about that as well in the neoadjuvant space, particularly with cetuximab. And then I will deep dive more on with respect to the immuno-oncology scenario for head and neck cancer. So EGFR is expressed in a large majority of head and neck cancer, and cetuximab is a monoclonal antibody against EGFR. The single agent activity is very, very limited, and this drug is being used in combination with chemotherapy. The pivotal phase 3 trial, EXTREME trial, with the primary endpoint of overall survival, looked at patients with recurrent metastatic head and neck cancer that were not previously treated with chemotherapy in the recurrent metastatic setting, and they were randomized to receive cetuximab versus cetuximab plus chemotherapy with cisplatin or carboplatin and 5-FU versus chemotherapy, with also a cetuximab maintenance in the investigational arm. And this is the first study that had led to an improvement in overall survival with overall response rate of 36% versus 20%. So a moving target, but one of the goals of systemic therapy, as I mentioned, is in improving overall survival. This treatment is not an easy treatment to tolerate and has associated with lots of toxicity. Now, looking into the more recent treatment that have been developed for recurrent metastatic disease, I've placed here a cartoon looking at cancer immunity cycle and some of the various targeting opportunity. What we have right now as a standard of care is really the anti-PD-1, but we'll touch base on all of the other steps of these cycle of cancer immunity cycle. So the very first drug that was has shown a benefit in the recurrent metastatic head and neck cancer was nivolumab, used as a second line in the platinum refractory. This was the CheckMate 141 trial, looking at patients who had progressed on the curative intent treatment, progressed on or within the 6 months of the last dose of the platinum-based chemotherapy. Patients were randomized to receive nivolumab versus investigator choice, and the primary endpoint was overall survival. There was indeed a benefit with a median overall survival of 39% for patients receiving nivolumab as compared to the investigator choice. The second and important pivotal study that had led to the development or the use of this therapy in the first line treatment as a standard of care was the KEYNOTE-048 study. So using immunotherapy in the first line setting for recurrent metastatic disease. This was a very large and complex study that looked at 3 main arms: single agent pembrolizumab versus pembrolizumab in combination with chemotherapy using a carboplatin or cisplatin and 5-FU, or the EXTREME trial, which was at that time obviously the benchmark. This study included also maintenance phases for pembrolizumab in the combo chemotherapy arm, as well as the cetuximab in the EXTREME trial. Now, the patient population baseline characteristic at that time, this is a slide taken from the ASCO 2019 presentation, show that the arms were quite balanced between. When we look at the comparison between chemo pembrolizumab versus EXTREME, what we saw is that there was a benefit on chemo pembrolizumab in the overall total population. This included all patients, regardless of their PD-L1 expression. And I pointed here on the left-hand side the results from ASCO 2019, and on the right-hand side the curves of the more recent publication, which was an update of 4 years outcome for this study, with a 48 months rate of 19% in the chemo pembro versus 4.5. Now I'm going to show you numbers of slides that have a similar pattern, but depending on CPS. So for when we break down the patients with combined positive score or PD-L1 expression, which is considered positive when patients have CPS equal or greater than 1, we can see that this benefit of chemo pembro stands, and it's actually increased as compared to the EXTREME regimen with 21, so 22% versus 4% at 48 months. And again, this is even more pronounced. This benefit is even more pronounced for patients who had a combined positive score of equal or greater than 20, which is considered PD-L1 high. In terms of toxicity, there's obviously toxicity in using chemotherapy, and we would expect that. And there were not a lot of differences, or perhaps even a better tolerance for chemo-pembro. Now, comparing in the same KEYNOTE-048 trial, pembrolizumab single agent versus extreme, what we saw is that, again, in the total population, the overall survival benefit was higher in pembrolizumab alone as compared to the extreme regimen, with a 15.4% overall survival rate at 48 months as compared to 6.6. And again, here you see the curves splitting a little bit more in the patients who are PD-L1 positive, so greater or equal than 1, and even about more in patients who are CPS high, or PD-L1 high. So when we look at toxicity, we now know many years after and been using this regimen, on a standard practice, is that of course pembrolizumab is much better tolerated than the extreme regimen, with lots of less toxicity seen. Now, so I've summarized here for you the first-line study in recurrent metastatic head and neck cancer. We had deep dive into the KEYNOTE-048, showing a benefit for immunotherapy or immunotherapy alone as compared to the previous extreme regimen. There's also data with respect to CheckMate 651, which was looking at nivolumab plus ipilimumab or cetuximab plus 5-FU and platinum with no major benefit, or no greatest differences at that time in all, and it was all randomized. Kestrel looked at anti-PD-L1 durvalumab or durvalumab plus anti-CTLA-4 tremelimumab versus cetuximab, 5-FU and platinum, and this was a negative study. So durvalumab versus extreme did not match its primary endpoint of overall survival improvement in the PD-L1 high patients. And then I have also mentioned here the KEYNOTE-B10. This is a single-arm study looking at pembrolizumab plus carboplatin and paclitaxel. It was obviously a smaller trial. This was a practical study because looked at a different chemo regimen as compared to the extreme, which, as we know, it's quite toxic, and the use of 5-FU is not patient-friendly, I would say. But a much more approach that at least it's used very commonly in North America, which was a choice of carboplatin and paclitaxel as a combination with pembrolizumab. As a result of this, and more frequently, we've been using carbotax as a choice of chemotherapy agent combined with pembrolizumab. And as you can see here, the median overall survival is 13 months, which was kind of reflective of what we were seeing between pembrolizumab and platinum and 5-FU, although obviously this is not a head-to-head proper comparison. In the second line, can immunotherapy be used and be of benefit? Yeah, we heard about it from CheckMate 141, nivolumab versus investigator choice, and also KEYNOTE-040, which is pembrolizumab versus investigator choice. And so these drugs can be used. However, I would say we use them less commonly, as our standard of care is obviously immunotherapy-based approach in the first-line setting. Now, just touching base a couple of minutes about toxicity. Importantly, immunotherapy, although it's well tolerated, can cause many different types of toxicity and affect virtually any organ of our body. We know that there are some toxicity that will occur earlier on in the treatment when we treat patients with immunotherapy, dermatological toxicity, colitis, and hyperthyroiditis can occur very frequently, but many others toxicity can occur at any time and point. And although most of them can be managed, we should not forget that it is very important to recognize the mechanisms of the immune-related adverse events. And the more we learned about those, the more we're able to kind of understand, predict, and more importantly, treat promptly our patients. Why? Because many of these toxicity can become chronic, and in some cases can be life-threatening events. And we should not forget that there have been toxic death from immunotherapy, even with single agent immunotherapy, although rare. Now, despite the fact that we have now incorporated immunotherapy in the treatment management for our patients, there are many unmet needs in the recurrent metastatic setting. Some general overall points of discussion are early predictors of response or resistant to immunotherapy. We still don't know much about it. Biomarkers that can differentiate pseudoprogression from true progression, we're lacking those. Optimal duration of immunotherapy responses. I think this is particularly important as many patients, while they're continuing to receive immunotherapy, and I should remind everyone that these patients can receive up to 2 years of immunotherapy. They can further develop toxicity that may be impairing their quality of life. And then also optimal number of chemotherapy cycle in combination with anti-PD-1. Do we really need the typical 6 cycle that we do carbotaxol or cisplatin 5-FU for this patient, or can this be limited? Now, specifically for the various subgroup of patients who are defined PD-L1 negative, who would respond to anti-PD-1 therapy, we do know that some patients do respond nevertheless, and this is limited to the fact that we only have a very overall a biomarker of responses that may not be sufficient to do. And what other combination could be used to improve outcome? For patients who are PD-L1 positive, and particularly CPS greater or equal or greater than 1, what combination beyond chemotherapy could be used to improve the outcome? And can this decision be more personalized? For patients who are high PD-L1 or expressor, I think it's important to recognize that there's still many patients that don't respond to immunotherapy in the monotherapy with monotherapy. So who would not respond? So we need to understand those patients, and then who would develop the resistance. Now, many other targeting opportunities have been in development, like 3-TIGIT, obviously VEGFR, so targeting angiogenesis, NKG2A, as well as ILT4, as well as IL2 and LAG3 at various steps of kind of the immune signaling. Now, I have mentioned here, and I should not forget the vaccine study as well. Now, I should say that many of these studies are still in development. I'll briefly touch base. We have data with respect to pembrolizumab and lenvatinib, which is anti-VEGFR inhibitor. There were a lot of kind of excitement, especially when we looked at the phase 1b and phase 2 trials. The cohort of patients who had recurrent metastatic head and neck cancer was small, but impressive kind of overall response rate of 48% was seen, which kind of drove the excitement to move into a phase 3 trial, looking at pembrolizumab with lenvatinib versus pembrolizumab placebo. And the overall response rate was high. However, the median overall survival was no difference, and that's why this trial was defined as negative. We also have a tactic study looking at FT in recurrent metastatic head and neck cancer. Again, lots of excitement in the phase 2 second-line trial with the confirmed overall response rate of 27%. But we just heard from Dr. Christensen at ESMO just a couple of days ago that the phase 2b study of TACTIV or TACTIV-3 in the first line recurrent metastatic head and neck cancer, which had CPS equal or greater than 1, had an overall response rate, no difference between single agent pembrolizumab plus versus pembrolizumab FD, and this was a negative, again, a negative study. Now, beyond that, we have anti-TIGIT antibody in combination with pembrolizumab. Skyscraper 09 looked at in the recurrent metastatic setting first line with PD-L1 positive, looking at tiragolumab with atezolizumab as compared to the placebo with an objective response rate with primary endpoint overall response rate by RECIST. We also have many other agents looking at TRK214 or IL-2 cytokine prodrug, again in the first line setting. This is the PROPEL 36 study with co-primary endpoint ORR as well as overall survival, large study. And then we have the ASPEN-03 and ASPEN-04 study, again in the recurrent metastatic setting, Bepatocet in combination with pembrolizumab with a safety lead-in, with comparison between the combination versus single agent pembrolizumab, which has been defined as a standard of care. This is true for both trials, looking at the very randomization. Now, anti-NKG2A with monalizumab plus cetuximab is also another important study that looked at overall survival as a primary endpoint with no benefit in overall survival, and this was closed. The Interlink study 01 was closed. Now, when we looked at ILT4, we have some data regarding MK-4830 in advanced solid tumor, which seems to be quite promising, and therefore more studies are built into that. And then finally, I just want to point out vaccine study, including the vaccine-inducing HPV-specific T cells plus nivolumab in the HPV 16 positive oropharyngeal cancer. And then another vaccine study, again, in the first line setting. Now, those are, I walk you through a marathon of clinical trials. And I think that as a take-home message is what I want to conclude with is that as a standard of care, despite all of this trial, despite all of the excitement, pembrolizumab either alone or in combination with chemotherapy remains first the standard of care in the first line recurrent metastatic setting, and that's no different for now, despite all of the trial. In the first line, I think you have seen it through the marathon of trials, is that this space is way crowded. It's probably way too crowded. Many ongoing trial, many plain study in the recurrent metastatic setting. The second line, not many, companies looked at this. It's definitely less crowded. Would need to have, a non-overlapping mechanism of action or ability to overcome immune resistance. And I think the bar is quite high here, and that's perhaps why there's not a lot of development. Although it's quite a pity because our patients live longer and they have, they need treatment option. Now, I want to stress the importance of biomarker, and that's because we need to really identify those patients who would need those therapy, who should be spared by those therapy. As I mentioned, toxicity remains an issue. So we need to do a better job in selecting the patients for the most appropriate treatment and having a proper algorithm. And perhaps we're not looking at just a single biomarker, but we're looking at multiple biomarker. We should leverage the novel techniques of multi-omics to look at a cluster of biomarker or specific signature that can predict responses. And unmet important need is the fact that we need to join efforts and to perform research to help to find the best solution. And I think that working together with the sponsor, cooperative trials, data sharing, as well as working earlier on with the regulatory agency in order to develop better and agile trial is probably the way to go. And with this, I want to thank you all for the attention.
Thank you, Dr. Sprayfeko, for that very, very insightful talk. And it's very nice to know that this space is getting more and more crowded. And hopefully, we'll have more regimens to tackle this persistent and recurrent disease. So let's move on to the next talk. So we also have a head and neck oncologist, a surgeon, to give a talk tonight. And we have Dr. Ratan Shetty. And I would call upon his twin brother, who is a medical oncologist. His name is Dr. Rachan Shetty, to introduce Dr. Ratan.
So at the outset, I would like to thank Dr. Vishwanath for heading this organization. And I would like to welcome all my dear colleagues. Dr. Ratan is my twin brother. He works as an associate professor in Department of Head and Neck Oncology at TMH Mumbai. And he specializes in ablative surgeries covering a full range of head and neck oncology with the focus on advanced and reoperative oral and thyroid surgeries. And at ACTRAC, he is instrumental in establishing skull-based surgery services, including anterior and lateral skull-based procedures. And he specializes in performing complex reconstruction using various local and regional flaps and additional training in microvascular reconstruction techniques. And he has numerous publications through Tata Memorial Hospital and ACTRA. Over to Dr. Ratan Shetty.
Yeah, thanks for a very generous introduction. So I'll be sharing my slides. And at the outset, I'd like to thank the organizing team, Dr. Vishwanath, for having me here. Talking about salvage surgeries in 10 minutes is a task in itself. So I'll try to finish in time. I'll make sure that. Okay. Yes. So we'll be talking about salvage surgeries. Today, I'll be talking mostly about oral cancer because a bulk of our work is oral cancer, over 80%, and a little bit of larynx and thyroid and all. But I would be only talking about oral cancer chiefly and a bit of laryngeal cancers. So what is salvage surgery? It is a surgical procedure after initial treatment failure. That is when you do a definitive treatment, the patient has a residual disease or a recurrence. And in early oral cancer, it is not 100% survival. 25 to 30% of cases in early oral cancer also recur, and 50 to 60% of cases in advanced oral cancer. The survival is around 40 to 50% in our setting. So what are the factors which help in decision making? The index primary. If it is a small primary, the chances of salvaging it when it recurs is higher. Disease-free interval, very important. The shorter the disease-free interval, the poorer is the outcome. Age and performance status has a bearing on the ability to perform salvage surgery. So coming to prior treatment, was it only surgery? Did the patient receive full gamut of treatment for head and neck cancer that also includes chemoradiotherapy? Then the outcomes are going to be difficult because the patient would not be able to receive adjuvant treatment. And in a poorly vascularized but in a heavily pretreated case, the chances of complications are also higher. The stage of the recurrent tumor, if it is a stage 4 tumor, the chances of salvaging it is also lesser. Again, the site of recurrence, if it's an anteriorly placed oral cancer lesion, that is very amenable for salvage. However, it is posteriorly placed, if there is recurrence in the neck, involvement of prevertebral fascia or the great vessels, chances of salvage is less. Again, coming to the anatomical and functional constraints, again, it has a bearing on the index primary. If it was a large resection which was done in the primary setting, the chances of salvaging becomes lesser. Comorbidities also has a bearing on surgical outcomes. Again, similar to what I had spoken previously, the challenges are multitude. Loss of tissue planes due to radiation fibrosis, heavily pre-treated surgical planes, can lead to various problems, and case selection becomes important. We'll discuss about what is more relevant. The disease-free interval is the most important. If the disease-free interval is less than 6 months, I would not try to salvage, unless it is in a new area where we have not treated it. In a treated bed, if it recurs within 6 months and it has been performed by the surgeon and our team, then I would not salvage such cases. But if it is a contralateral neck node, probably we could salvage, even if it's less than 6 months, we can. Also, so the limited surgical margins due to anatomical and tissue constraints. This is a salvage surgery that we performed recently. See the amount of resection which needs to be done. But this had the index primary was the early oral cancer, so we could salvage it when it recurred. The record probably after a couple of years. Now, what is the most important in salvage surgery? Resection with adequate margins and receiving adjuvant treatment is the treatment of choice for oral cancer, and it has shown the best survival in for primum setting and in salvage setting. Enough evidence to say that surgery followed by adjuvant is the best treatment for oral cancer. Local versus local regional recurrence. The site of recurrence has a bearing. If and in oral cancer, the most common site of recurrence is oral cavity. 42% of the time, the recurrences occur in the oral cavity. Many times, you will have second primaries in the oral cavity, infield tumors, which may or may not be salvaged. And the salvage rate varies across the world. In Indian setting, it is usually in the single digits, like 8 to 10%. In tertiary centers, it will be low 20s, but in Western setting, it will be around 25 to 40%. Local recurrences carry better prognosis than regional and local regional recurrences. And the site of the primary, that is tongue cancer, had a better cumulative overall survival than those with uh, local regional recurrence. Those who had primary recurrence versus local regional recurrence had better overall survival. And when you do a salvage surgery, a positive surgical margin is a poor predictor. And margin assessment also becomes difficult because of the fibrosis which is involved. You usually tend to send the patient, send the specimen for frozen section evaluation. Always do frozen section evaluation if you are unsure of the margins, because the facial peelings and all are disturbed because of radiotherapy. Regional recurrences, the most common site is level 2 nodal region, and the treated area is the one where it recurs, not in the untreated area. Unusual regional recurrences like intraparotid, prelaryngeal, or retropharyngeal nodes have a poor prognosis. And study by Mizrachi et al., 1,300 patients of oral cancer for regional recurrence. In RT-naive patients, 15% of the patient developed regional recurrence, and 87% of the patient underwent salvage treatment. Those who are RT naive, obviously you can salvage, but doing post RT setting, ability to do a salvage surgery also becomes a challenge. Then these are the cases which are unsalvageable: encasement of great vessels, involvement of skull base, involvement of prevertebral fascia, mediastinal involvement, and involvement of skull base bones. These I wouldn't touch these such cases, and the treatment becomes systemic treatment. Advanced neck recurrences. Again, you can see a patient who has presented with skin nodules, central compartment neck node, which are unresectable. And the outcomes depends on the site and size of the tumor, the interval between the recurrence, and it has a bearing on functional outcomes also. This is a review article by Alan Ho, where he showed that salvage surgery with adjuvant treatment has the best survival, and the overall survival is the best with salvage surgery followed by adjuvant treatment. Even the quality of life is improves when it is a smaller recurrence compared to a advanced recurrence. That is, a stage 4 recurrent tumor has poor survival and poor quality of life. What are the factors which is important in deciding site? The short DFI is the most important factor in out, and it's an independent of site. 20% difference in OS over 5 years. That is when DFI is less than 9. Positive tumor factors, like I mentioned earlier, early recurrent tumors, long disease-free interval, and laryngeal primaries has a very good salvage rate. Another systematic review, which again confirms the things that I said earlier. And the best survival that you can achieve is in larynx and oropharynx, where the survival is between in 37%, 40% and 37%. That's studied by Lee et al. In oral cancer, you would not have this kind of survival. The survival is in the 20s, low 20s to mid 20s. What is important in preoperative evaluation? Imaging. PET-CT is the standard of care. If you are in doubt, you can get an MRI, diffusion weighted MRI, which will help you in help you in seeing the tissues. And all the cases should be discussed in a multidisciplinary team and do a preoperative anesthesia evaluation. And Functional status also has to be taken into account, and the patient's motivation also, if he is willing to undergo a salvage surgery, because these surgeries are quite complex. Surgically, I would not go much into surgery in this thing. The surgically, what you need to do is, see, in a treated neck, you have to plan your incisions well. If you don't plan your incisions well, the patient can have flap necrosis or complications, and the flap needs to be raised with the knife rather than an electrocautery, because of post-RT setting, the chances of flap necrosis occurs if you are not very careful in maintaining the vascularity of the skin flaps. Early stage index primary, this was a case who had an early oral cancer, developed recurrence, ended up having a segmental mandibulectomy with reconstruction with a flap. This is a patient who had again early oral cancer, but presented with an advanced primary, who ended up having a total maxillectomy, the ITF clearance with segmental mandibulectomy. You can see the globe here, total max. We salvaged him about 6 months where he's still alive, but the prognosis is guarded. Another case where he underwent an ITF clearance for a radio recurrent tumor. He was, borderline resectable, so we gave neoadjuvant chemotherapy, was amenable for resection, partial response, had some tumor in the ITF, did an ITF. Coming to complications of salvage surgery, overall complication rate is much higher than in primum setting. It encompasses wound infection, flap necrosis, fistula formation, wound dehiscence, seroma, and carotid blowouts. Carotid blowout is not very common now because of the advent of free flap reconstruction. The free flap reconstruction makes our cases amenable for resection because we can reconstruct the thing. This was not the case maybe 20, 30 years ago. Because of the advent of free flap reconstruction, we can salvage most of the, if it is resectable with margins. And functional complications, like patient may be tube dependent, tracheostomy tube dependent or feeding tube dependency. And in a study by Agra et al., the overall complication rate was around 37%, whereas in preprimum setting it is less than 10%. Radiation-induced osteoid necrosis also occurs because if the patient receives re-irradiation, the dosage crosses 100 Gray, and patient is much more susceptible for osteoradionecrosis than in perforamin. So these are some of the pictures where patient develop flap necrosis due to incision planning, wound breakdown post salvage surgery. Flap necrosis can also occur. Patient underwent a flap reconstruction because the vessel quality was bad because of radiation, developed flap necrosis. What are the factors which affect surgical outcomes? The ability to reconstruct, postoperative complications, positive margins. Hello. Keep through this follow-up after surgery. Most of the patient survival is not very great. 20% develop distant metastasis on follow-up, and 50 to 60% of the patients develop re-recurrences, and re-recurrences many of times will not be salvageable. And the second re-recurrence is also important in predicting prognosis. Pattern, most of the time it is local recurrence. Regional recurrence is also common. Local regional recurrence. Just doing a salvage surgery may not be feasible. You need to treat the patient with adjuvant radiotherapy. And here is a study where it has shown that doing only surgery may not be enough. Quality of life after salvage surgery decreases. I mean, the quality of decreases, as I mentioned before. I'll skip to this recurrent laryngeal cancer. Recurrent laryngeal cancers are very amenable for salvage surgery. And even if it is feasible, you can also do an open partial laryngectomy, and the functional outcomes are also acceptable when you treat a larynx. So it's a standard of care, that is chemoradiotherapy for cancers uh, uh, which are amenable for organ preservation. Also, it has also its complications, but yes, it is a standard of care now. You can also do TORS for oropharyngeal primaries or supraglottic primaries, but it is all should be done in those who are well trained in doing these procedures. Minimally invasive techniques like transoral endoscopic ultrasonic surgeries or transoral robotic surgeries has improved functional outcomes by accessing the tumor without going through tissue. Take home message: salvage treatment. Always do salvage wherever it is feasible. Selection of patient is important. Well-preserved younger patients, early stage recurrences, and only in certain advanced stage recurrences. And whenever the disease-free interval is more than 9 months or at least a year since the previous treatment. Do a PET scan and an MRI scan whenever required. balance outcomes with mobility and quality of life, always reconstruct and discuss these cases in multidisciplinary clinic, and radiation or chemoradiation is warranted in most salvage surgeries. Doing only a salvage surgery without giving radiation or chemoradiation is not a feasible way of approaching the case. Thank you.
Yeah. Thank you, Ratan, for that nice talk. So shifting gears, let's move on to the case presentations. And I would like to call upon our first case presenter, Dr. Ram Gopal Rao Valla, and he's a resident in the Department of Medical Oncology in Basava Tarak Rama Institute in Hyderabad. Dr. Ram Gopal Rao, you can start. Be crisp so that there is time for some questions, and that way and I call upon all the experts, Dr. Ratan, Dr. Anna Sprefico, and Dr. Rajiv Rajendranath to participate in the discussion as experts. Yeah, please go ahead, Dr. Ram Gopal.
Yeah, good evening. Thank you everyone for giving me this opportunity. And I'm presenting the case. Mr. Yella is a 60 years male and advocate by profession and is resident of Hyderabad. So with chief complaints of non-healing ulcer over the left buccal mucosa for 2 months duration. So this non-healing ulcer was not associated with any pain, and there is no difficulty in opening mouth and difficulty in chewing. There is no history of any trauma, and there is no history of any neck swelling. So past history he is a hypertensive since 6 years and on regular medication, and he is a chronic smoker, and he has 24 pack years history of smoking, and there is no other history of tobacco chewing and other forms of tobacco, and there is no family history of any malignancy. Coming to his general condition, his ECOG performance score is 1, and on local examination, there is a mouth opening of 1 centimeter, and there is a poor oral hygiene, and oral submucosal fibrosis is present. And there is an ulcero-infiltrative lesion on the left buccal mucosa of size 4 into 3 centimeter, extending from second premolar to last molar and retromolar trigone, involving the upper and lower gingivo-buccal sulcus, and there is no involvement of gingivolingual sulcus, and anterior tonsillar pillar is free. And on external examination, the left cheek swelling of size 3 into 3 centimeters and skin is normal, and there is no palpable neck nodes. Coming to the investigations, biopsy from the left buccal mucosa lesion showed squamous cell carcinoma, well differentiated type, and CT head and neck was done, and it showed ill-defined heterogeneously enhancing soft tissue, dense thickening noted involving the left buccal mucosa and upper and lower gingival buccal sulci and retromolar trigone, and closely abutting the medial pterygoid and masseteric muscles. And there is a enlarged lymph node noted in level 1A and level 1B and level 2, measuring around 16 to 9 millimeters, suggestive of metastatic, and the impression is future suggestive of carcinoma left buccal mucosa CT4A N1 stage 4A. So he underwent surgery in July 2023, left composite resection with flap reconstruction, and so post-operative histopathology report shows this is an invasive squamous cell carcinoma, well differentiated type, and greatest dimension is 3.5 centimeter, and maximum depth of invasion is 2 centimeter. And there is a perineural invasion is present, and LVI is indeterminate. All margins are free of tumor, and the closest margin is posterior margin, which is 0.6 centimeter away from the tumor, and overlying skin and circumferential skin resected margins are free of tumor. And out of 25 lymph nodes resected, there is a level 1B lymph node which was involved by the tumor, and there is no ENE, and salivary gland is also free of tumor. And coming to a pathological impression, it is a squamous cell carcinoma of left buccal mucosa PT4A-N1. So he underwent adjuvant RT with a total dose of 60 grain 30 fractions from August to September 2023. So there is a disease-free interval of 6 months, and in February 2024, he complains of left ear pain for since 2 months duration, for which PET-CT was done. It shows increased FDG uptake and enlarged heterogeneously enhancing necrotic left parapharyngeal lymph node measuring around 2.3 into 2.2 centimeter with SVP max of 12.3, and there is a mild FDG uptake in few small subcentimetric right level 2 lymph nodes, which are considered reactive. So it was considered as a recurrence in a known case of carcinoma left buccal mucosa. This was a PET CT which was done in February 2024. It was showing a left par. So surgical opinion was taken, and surgeon opened as inoperable, and PDL1 testing was done in the surgical specimen that CPS was less than 1, and he was started on TPEX protocol, including docetaxel, cisplatin, and cetuximab from Feb 2024. So post 3 cycles of TPX chemotherapy, comparing with the February 2024 PET CT, the PET CT in April 2024 shows there is a decrease in size and metabolic activity. And post 4 cycles of TPX, followed by maintenance of cetuximab, and PET CT was repeated in September 2024, which shows there is an enlarged FDG avid necrotic left parapharyngeal lymph node measuring around 3.1, which is increased in size, and there is a increase in SUV max also, and there is an increased FDG uptake in left mandibular alveolar process, which was new. So this was the PET CT, which was repeated in September 2024. It shows the. So further discussion regarding these cases, this is already first line recurrent treatment was done, and what is the further lines of management, and is there any, what is the role of the standard dose immunotherapy versus low dose immunotherapy with or without OMCT, and is there any role of rebiopsy for doing again CPS score, and is there any role of salvage surgery in again second line? These are the questions.
So can we have Dr. Anna Fico for the first question?
Yeah,
the further line of
Yeah, so thank you for presenting this interesting case. I think that, if this is a patient that I would see in my clinic, the very first thing that I would do is to bring it to the tumor board discussion, okay? I think that's very important, that all of the message I want to give is that very important that all of the discipline work together in order to find the best next step for this patient. Now, with respect to further line of management, I think that the very first thing that I would, if available, I would do is to take a piece of the tumor, not so much because I'm worried that this is a different type of cancer, although, things can happen. But I'd like to understand, and then it depends on availability here, but I would like to understand what are the molecular characteristics of this tumor. So in an ideal situation, I would have some tissue that I could profile, okay? That may not help me directly to identify what next steps of line, if it takes some time for this molecular profiling to report, but I'd like to see it because it might help me to match this patient to a therapy along the line. And that can increase treatment opportunity for our patient. Next thing that I would do is, as our, surgeon is already doing a biopsy, is to really understand from a multidisciplinary standpoint whether or not this patient would benefit from a salvage surgery. And so I will ask, my colleague surgeon, and I would offer a potential systemic therapy as a next line. If I don't have molecular profiling, I might consider immunotherapy, but I would want to know whether or not this patient may have an option from a surgical standpoint, taking into consideration the clinical, the outcome of the surgery, as well as the potential long-term severe toxicity that the patient will go on. I can touch base on, maybe I can let the other speak, and then I can touch base regarding the second bullet point.
Dr. Rajiv, we have some data in India with low dose immunotherapy and oral metronomic chemotherapy. Your thoughts on that for the second question?
Yes, I would agree with most of the points that the first speaker raised. One thing, yes, we have interesting data about low dose immunotherapy with oral metronomic, and many of us have had good responses and sometimes exceptional responses, but that's not always the case. So here he has mentioned he's a lawyer, so I assume he's reasonably well off. So in that case, I will have a discussion with him, and if he's okay to go with the standard dose IO, I would use standard dose IO, and that would be the systemic therapy. Oral metronomic chemotherapy, I would keep it as the next line maybe, because we'll give him one more chance. But as correctly pointed out, there should be an MDT discussion and involve the surgeon and discuss regarding the role of salvage surgery.
Yeah. Any further thoughts, Dr. Anas Prefeco? For I think you've answered the last two questions as well in your first. As part of.
Yeah, we don't have, like in North America, we don't use the low dose immunotherapy with the metronomic chemotherapy. There's no level 1A evidence that I'm aware of. I think this patient, it's the type of patients that I mentioned before. It's CPS negative, but we know that some patients may respond to immunotherapy. My option, in the ideal situation is either matching it to a clinical trial or enrolling him in a clinical trial. And if I don't have any other option, I probably attempt immunotherapy for this patient as not receiving. And we know that some patient may respond regardless of the CPS if there is no other curative intent option.
Sure. Thank you, Dr. Ram, and we'll move on quickly to the next case.
Thank you,
Very
sir.
nice presentation, Dr. Ram. So the second case presentation, Dr. Padmini, can you start your case presentation?
Good evening. Hello, good evening. Thank you for providing me this opportunity. So, today I'll be discussing a case of a 40-year-old female who's a homemaker who presented to us with a neck swelling and an oral tongue ulcer of 1 month duration. So there was a right-sided neck swelling of 1.5 month duration, which had progressively increased in size with no pain or skin changes, and ulcer on the right side of the tongue, which had progressively increased over the last 1 month, associated with pain that was non-radiating, with no other symptoms. So coming to the past history, she was a known case of hypothyroidism on treatment, otherwise with no significant family history or no ill habits. On examination, she was ECOG PS1. Her oral hygiene was adequate with adequate mouth opening and no dental caries. A large ulceroproliferative lesion was noted on the right lateral border of the tongue, measuring about 3 into 2 centimeter, involving the posterior one-third of the oral tongue. The tongue movements were normal. There was no deviation of tongue. On palpation, there was induration surrounding the lesion, and the lesion was about 4 centimeter from the tip of the tongue and 1 centimeter medially from the midline, and posteriorly extending to the base of the tongue, and the floor of the mouth was not involved. On indirect laryngoscopy, the lesion was seen extending into the base of the tongue. The rest of the structures were normal. Apart from that, there was no other oral lesion. And on neck examination, there was a right-sided upper jugular cervical lymph node, about 3 into 3 centimeter, hard and non-mobile and non-tender. There was no other palpable node. Her blood workup was normal, echo was normal. On biopsying the tongue lesion, it was reported as squamous cell carcinoma, moderately differentiated, and the right cervical lymph node showed metastatic squamous cell carcinoma. On PET-CT evaluation, there was uptake seen in the bilateral palatine tonsils and at the base of the tongue, and there were bilateral lymph nodes, and FTG uptake was noted in multiple right-sided nodes in the level 2, level 3, and level 4 cervical nodes, and on the left side, level 3 cervical node measuring 1.2 centimeter with a SUV of 24. So a diagnosis of squamous cell carcinoma of right side of the tongue was made. Clinical staging was CT3, N2, M0, stage 4A. The patient's case was discussed in the MDT, and our considerations was whether to post this patient for surgery followed by adjuvant therapy or concurrent chemoradiation, or whether to consider induction chemotherapy followed by reassessment for surgery or radiation. As discussed in the MDT and decided, she underwent neoadjuvant chemotherapy with docetaxel, triptan and 5-FU for 3 cycles, 3 weekly. And further assessment showed persistence of the bilateral nodes. However, there was reduction in the size of the nodes. The right-sided largest node had reduced from 2 centimeter to 1.6 centimeter, and the left side node had come down from 1.2 to 9 into 6 mm, and the tongue lesion had reduced. So she further underwent right partial glossectomy and bilateral neck dissection, and histopathology showed squamous cell carcinoma grade 1, tumor size of 0.3 centimeter with a depth of invasion of 2 millimeter. There was no lymphovascular invasion or perineural invasion noted. Margins were uninvolved. The right side neck dissection specimen showed 8 out of 42 nodes had metastatic nodes, and the largest metastatic deposit being 0.8 centimeter. There was extra nodal extension noted. The left-sided neck dissection was showed 0 out of 17 nodes. So at this point, the role of adjuvant concurrent radiation or chemoradiation was discussed, and she underwent concurrent chemoradiation. She received 5 doses of weekly cisplatin and radiation to the right side tumor bed and the post-op bed and the right-sided nodes, and also the left-sided cervical node. So my questions to the panelists is the assessment of resectability of tumor first to start with, and then how do we sequence the therapy? At what point do we consider the patient for induction chemotherapy followed by surgery, and its impact on the survival, and in terms of adjuvant therapy, whether radiation or chemoradiation?
Dr. Anna, do you want to
Thank
take the
you.
first question?
Yeah, so I think that with respect to obviously the resectability of the tumor, I'll have to defer to my colleague surgeon. I think one important thing here in this case is that I would ask the surgeon to see whether or not he or she thinks that the induction chemotherapy had made an impact with respect to the resectability of the tumor, as well as a really modify the resection. Because if ultimately the patient has to go through the same extensive resection that would do it up front when the cancer was diagnosed, I think we're missing here the benefit to the patient, as obviously we're adding toxicity. We want to be as aggressive as possible, but we need to take into consideration. So my question is, knowing what happened, had really the surgery, and this is a question for the surgeon, had really the surgery been modified as a result of the neoadjuvant approach? Because I think these are the cases that, that are resectable, stage 4A, but like bulky tumors that they're becoming very complex to do surgery. And in that case, I think that I would favor neoadjuvant should there be really a potential good impact on the extent of the surgical result. And then with respect to chemo, post concurrent to radiation, depending on the risk factor, my understanding was that this patient had risk factor at extranodal extension, if I'm not missed, and that would qualify for that. So this patient have had neoadjuvant surgery and then the full blown of post-operative chemoradiation, lots of toxicity, lots of long-term toxicity. Like, have we avoided a bigger, larger surgery in this case?
Thank you, Dr. Anna. Dr. Ratan, quickly, would you go for neoadjuvant or would you go for upfront surgery in this particular patient?
I would have operated this case, probably would have done a 3B or a type 4 resection followed by with the bilateral neck dissection. I would not have given neoadjuvant chemotherapy for this case because it was eminently operable.
Sure.
So I don't think we have changed the the extent of resection.
Sure.
Patient eventually underwent a partial glossectomy with bilateral neck dissection, and yes, like I agree with the Dr. Anna, the toxicity involved in neoadjuvant in a case which has no indication. I don't know. I wouldn't have done it.
Dr. Reggie, we have heard a lot of talks of yours on neoadjuvant chemotherapy, systemic therapy in head and neck. Your thoughts on this particular patient?
I think I had made it very clear with the caveat that it's not the standard of care for all patients. In this case, I would agree with the other panelists with surgery, and then probably we would need a trimodality treatment. he would get a chemoradiotherapy later, because we know that she's young, tongue is very aggressive, very high chances of nodal micrometastasis, which she has proved. Because even after neoadjuvant chemo, when we have the extranodal extension and other high risk features, that just shows that the neoadjuvant did not do the job it should have done. So yeah, I think it would have a lot of MDT discussion. I think that's what would have happened in this case also, because being young, whether we can do something different, whether we should offer the benefit of neoadjuvant. But most of us would have gone for surgery, and most of the time she would have received adjuvant chemoradiation also.
I think one of the, if I can add, I think one of the important components that this would be a perfect patient that we would consider, for example, in the context of a trial, we would consider a neoadjuvant approach with immunotherapy base. Like you've mentioned, right, before during your neoadjuvant, because of the antigen is there, whether or not this patient would receive it. We don't have the data yet. Hopefully will come up some data, some of the trial are wrapping up and hopefully presented soon to see whether or not there is a role in this case.
Sure. Dr. Padmini, would you like to, as we're running short of time, can you quickly summarize, or it's done? So that's what did the patient receive finally?
So she did receive neoadjuvant chemotherapy. She underwent surgery and she received chemoradiation. And she's been doing well on follow-up. It's been about a year and a half. Recently, she had come for a follow-up, and yes, she did struggle with toxicity at some point. She did have some oral pain and ear pains, for which we had to do a repeat scan. But there's no evidence of recurrence, and she continues to do well.
Very nice. Very nice case presentation. Thank you, Dr. Padmini and Dr. Ram, for those very interesting cases.
Thank you, sir.
Now I would like to call upon Dr. Poonam Maurya for the concluding remarks and summary.
Thank you, everyone. A heartfelt thank you to Dr. Anna for her comprehensive and insightful presentation, as well to Dr. Rajiv, sir, for his perspectives on neoadjuvant systemic therapy. I'd like to express extreme gratitude to Dr. Ratan Shetty also for his excellent overview on salvage surgeries and head and neck cancers. And a special thanks to Dr. Padmini and Dr. Ram Gopal, well done for their case presentations, and to the experts, of course, for actively participating in the discussion. Our sincere appreciation goes to the entire ASCO team, particularly Ms. Sarah and Ms. Jessica, for their unwavering support and encouragement in organizing this particular event. Also, want to extend my deep gratitude to Dr. Vishwanath S., whose dedication has made this webinar possible. And of course, all my fellow CPOM trustees, Dr. Santosh, Dr. Rachan, and Dr. Chandrakant, for their continuous support. A very big thank you to all the audience who has participated actively and has made this webinar truly successful. I'd like to also acknowledge today's sponsors, NATCO and OncoMinds, for their generous contributions. And a special thanks to Mr. Vijay for his invaluable contribution to the logistics of today's webinar. Thank you once again, everyone. We look forward to seeing you for our upcoming ASCO-sponsored CPOM webinars. Thank you. Have a wonderful day.
Thank you to the entire organizing team.
Thank you.
Thank you for all.
Thank you.
Thank you.
Thank you so much. Thank you, Sarah and Jessica.
Take care.
Thank you, Rajiv, sir.
Cheers, folks. Take care.